Medicos. Good day to all of you. This is Dr. BK for you, and today I will be discussing about the thyroid gland. Now, before discussing about the thyroid gland, I will be just giving a short introduction about the midline structures of the neck. So the anterior midline of the neck. So what are all the structures are lying, and followed by that the paramedian structures. Then I will be discussing about the thyroid gland in detail under the following headings, that is its situation, coverings, presenting parts, relations, blood supply, development, and then the clinical aspects. Now, first let us try to understand the midline structures of the neck. So here you are able to see the neck. The anterior midline extends from the symphysis menti to the manubrium sternum. So it is covered from superficial to deep by the skin. Deep to the skin in the superficial fascia you have the platysma muscle, which is supplied by the cervical branch of facial nerve. The function, it raises the skin of the neck and also relieves pressure on the underlying veins. Then deep to the superficial fascia you have the deep fascia of the neck, which is called as the investing layer of deep cervical fascia. The investing layer actually encloses the sternocleidomastoid, then fuses and then splits to enclose the trapezius muscle. Same way, if you trace the investing layer above, it is attached to the lower border of the body of the mandible up to the angle, and then it actually continues as the stylomandibular ligament. Below, it is actually attached to the manubrium sternum and then the clavicle. Now, the structures in the midline of the neck can be categorized into above the hyoid bone as the suprahyoid structures and below the hyoid bone as the infrahyoid structures. Now, deep to the skin, I told you the superficial fascia, which also has cutaneous veins, vessels, and the nerves. Mainly, the anterior part of the skin of the neck is supplied by the anterior cutaneous nerve of the neck, which is from the cervical plexus. Then, you also see the anterior jugular vein. Okay. So mainly you come across the anterior jugular vein, which actually starts in the suprahyoid region by the union of these small veins, and the main trunk of the vein you can see on either side of the midline. And what happens is these veins, they go and terminate or drain into the external jugular vein after passing deep to the sternocleidomastoid. Both the anterior jugular veins are actually connected to each other by a jugular arch. Okay. So then these are all the superficial structures. Now, deeper, if you go deeper in the deep fascia, deep to the deep fascia, what you see here is the suprahyoid structures, and mainly it is formed by the mylohyoid muscle. It is also called as the diaphragma oris or oral diaphragm, and on either side by the two anterior bellies of digastric. So these two are actually suprahyoid muscles. This muscle is responsible for elevating the floor of the mouth and also the hyoid bone. The anterior belly of digastric helps in depressing the mandible. Then, submental lymph nodes is very important because they drain the tip of the tongue and also the central part of the lower lip and the adjoining gum region, and they also drain the submental region. So all these things I have described in the anterior triangle of the neck, in the muscular triangle and the submental triangle. Okay, so suprahyoid, mainly you see the two anterior bellies, then you see the mylohyoid muscle, and then you see the submental lymph nodes. So enlargement of the lymph nodes, naturally you should actually suspect for any infections or carcinoma of the tongue, mainly the tip of the tongue. Now, then I told you this is the hyoid bone. It has a central body and it has got a lesser horn and a greater horn of the hyoid bone. Now, this hyoid bone is held in its place only by the muscles. Okay, and what happens is the infrahyoid muscles, they help to depress the hyoid bone and the larynx, whereas the suprahyoid muscles elevate the hyoid bone and thereby they also indirectly aid in elevating the larynx. Okay, infrahyoid structures in the midline, mainly you see between the hyoid bone and the thyroid cartilage, is the thyrohyoid membrane. The thyrohyoid membrane is thickened in the midline to form the median thyrohyoid ligament. This is the median thyrohyoid ligament, and this is the thyrohyoid membrane which will be pierced by the internal laryngeal nerve, which is a branch from the vagus nerve. This is the angle of the thyroid cartilage which you are seeing. The angle of the thyroid cartilage is actually more pronounced in the males. Okay, the angle increases in case of the males, and that actually is responsible for the deep voice in the males, especially after puberty. This change occurs, whereas in females there is not much change in the angulation, and this is actually called as the laryngeal prominence. Okay, that is actually called as the laryngeal prominence, the angle of the thyroid cartilage where the two lamina of the thyroid cartilage, they meet. Below that, what you are able to see here is the cricoid cartilage. The cricoid cartilage, the anterior arch of the cricoid cartilage you are able to see here, and between the arch of the cricoid cartilage and the thyroid cartilage you have the cricovocal membrane, which is actually a membrane of the larynx. Then below that you have the first tracheal ring, and between the cricoid cartilage and the first tracheal ring what you see is the cricotracheal membrane, and then second, third and fourth tracheal ring is actually covered by the isthmus of the thyroid gland. So isthmus is actually the central connecting part which connects the two lateral lobes of the thyroid gland. Then below the isthmus of the thyroid gland you see the emergence of the inferior thyroid vein. On either side paramedian you will be able to see the infrahyoid muscles. The infrahyoid muscles present in two layers. Superficial layer is the sternohyoid and then omohyoid. Deeper layers you have sternothyroid and thyrohyoid. More deeper you go, you will see the cricothyroid muscle, and then posteriorly the inferior constrictors. Okay, so either side the lobes of the thyroid gland you can see, and this is actually the pyramidal lobe which extends from the upper part of the isthmus of the thyroid gland and not always present. So other structures, mainly I told you the isthmus of the thyroid gland, then the pyramidal lobe, and you see a fibromuscular extension which is called as the levator glandulae thyroideae. Then you see the anastomosis of the superior thyroid artery. both the superior thyroid arteries of the both the sides. They anastomose on the upper border of the isthmus of the thyroid gland. Then I told you the commencement of the inferior thyroid vein. Now why? Actually, a knowledge of these structures, especially the anterior midline, is necessary. Now, all the viscera in the cervical region is actually situated in the anterior midline. Thyroid gland, trachea. Behind the trachea, you have the esophagus. In the lower part, especially in the infants, you can see the thymus gland, which is a primary lymphoid tissue, produces T lymphocytes. Then it is replaced by fibrous tissue as the grow up. Even in children, what happens is the great vessels, the arch of aorta or the brachiocephalic vein, so they are also present in the lower part of the neck. Okay. So then the nerves, mainly the internal laryngeal nerve piercing the thyrohyoid membrane. In the tracheoesophageal groove, you see the recurrent laryngeal nerve which is going to supply the muscles of the larynx, mainly the intrinsic muscles of the larynx. So, a knowledge of these structures is very, very essential for surgical as well as for clinical aspects. For example, in endotracheal intubation or when you are going to do a tracheostomy, so in adults, what happens is lower tracheostomy is advised. But in children, the lower tracheostomy is actually not advised because, as I told you, the greater vessels, the great vessels are actually present. They have not still descended. They are actually present almost near to the root of the neck. And same way, any surgeries of the thyroid, especially partial or total thyroidectomy. So while ligating these arteries, you should be very careful. And in any lymph node dissections is also very, very important. If you are going to the removal of lymph nodes in carcinoma also, so you should try to preserve the major vessels and the nerves. And that is why the knowledge of these midline structures of the neck is essential. With this introduction, I will pass on to the thyroid gland. It is an endocrine gland. It is a ductless gland. You all know that. You would have actually studied thyroid gland in detail in your higher secondary school level. Okay. So, it is situated in the neck and it actually clasps the trachea on either side of the trachea and in front of the trachea. It is an endocrine gland, ductless glands, so naturally the secretions are poured directly into the blood, rich blood supply. So, it has got a very rich blood supply. Then one peculiarity of this is it synthesizes, stores and releases its secretions whenever necessary. So secretions are mainly T3 and T4. Then not only that, it is the only endocrine gland which is dependent on the external environment for the synthesis of the hormones. So that is the iodine. So iodine, what happens is, it is present in the form of iodide and that has to be oxidized by the peroxidase. And then what happens is, thyroglobulin will act with this iodide and then for the formation of T3 and T4. So after the T3 and T4 is formed, the iodide is again used up. Okay. So with this short introduction on the function of the thyroid gland, so I will pass on to the gross anatomical features of this gland. So where actually it is situated, the thyroid gland? It is situated from 5th cervical vertebra to the first thoracic vertebra, C5 to T1. With respect to trachea, it actually extends up to the fifth or the sixth tracheal ring. Okay, it extends up to the fifth or sixth tracheal ring, and vertebral level is C5 to T1. The coverings of the thyroid gland, it has got a true capsule and it has got a false capsule. The true capsule is mainly formed by the condensation of the fibrous stroma of the gland. The false capsule is mainly formed by the pretracheal fascia. The false capsule is the outer capsule and it is formed by the pretracheal fascia. So here you are able to see a cross section of the neck. So platysma muscle, you are able to see this thin line in the fat. And then this is the investing layer, which is the outermost layer of the deep cervical fascia, which encloses your sternocleidomastoid and trapezius muscle. This is the pretracheal fascia, which encloses the thyroid gland, and since it is present in front of the trachea, it is named so. Then, in front of the vertebra, you have the prevertebral muscles, which is covered by the prevertebral layer of deep cervical fascia. The carotid sheath, which is again a modification of the deep fascia, is derived from the pretracheal layer as well as the prevertebral layer of deep cervical fascia. The pretracheal fascia splits to enclose the gland, and if you trace further above, it is attached to the oblique line of thyroid cartilage and further above to the hyoid bone. If you trace the pretracheal fascia below, after enclosing the gland, it again fuses and gets attached to the fibrous pericardium. So it is attached to the fibrous pericardium. Since it is attached to the oblique line of the thyroid cartilage, any tumors of the thyroid gland cannot extend above. It can extend posteriorly or medially and compress these structures, but it cannot extend above. Okay. Then, so that is about the false capsule. Now, deep to the false capsule, you have the venous plexus. So, the veins of the thyroid gland, they start as the plexus, from a plexus, venous plexus, which is present deep to the true capsule. So, deep to the false and also the true capsule, it is actually lying on top of the gland. Between the true and false capsule, you have the blood vessels, the trunk of the blood vessels, which is going to supply the thyroid gland. Okay, which is going to supply the thyroid gland. The trunks of the blood vessels you can see in between these two. And one more important structure which you can see is the parathyroid glands between the true and the false capsule. Posteriorly, you should be very careful to identify that gland and preserve it while doing thyroidectomy. The ligament of Berry is actually from the oblique line of thyroid cartilage. You can see an extension or thickening of this pretracheal fascia, which is actually called as the ligament of Berry. Okay, so that is about the true and the false capsule. Now, coming to the presenting parts of the thyroid gland. So, I told you in the beginning, it has got two lobes, lateral lobes, connected by an isthmus. Okay, and it is roughly butterfly shaped or H-shaped structure. Each lateral lobe has an apex, base. The upper part pointed one is actually called as the apex, and the lower expanded part is actually called as the base, and it has three surfaces and two borders. The apex is actually sandwiched between the inferior constrictor and the sternohyoid muscle. Okay, so it is almost present in the narrow space between the inferior constrictor and the sternothyroid muscle, and you can see the superior thyroid artery actually dividing into anterior and posterior branches at the apex. Not only that, near to the apex, the superior thyroid artery and this nerve you are seeing here, the external laryngeal nerve, diverges near to the gland. These two structures, they diverge or separate. Before that, they actually travel in close proximity to each other. The external laryngeal nerve supplies the cricothyroid muscle of the larynx. It is the only intrinsic muscle of the larynx which can be seen on the outside or external aspect. Okay, so the apex is related mainly to the superior thyroid artery, and both the superior thyroid artery and the external laryngeal nerve, they actually diverge as they approach the gland, nearer to the gland. In regard to the base, opposite the fifth or sixth tracheal ring, here what happens is it is related to the loop of inferior thyroid artery, where the recurrent laryngeal nerve is in close proximity. So nearer to the gland, the artery and this nerve, they come close to each other. Here the artery and nerve, they actually separate near to the gland, but here they are actually in close contact. They approximate or they converge with each other. Okay, the recurrent laryngeal nerve which you are seeing in the tracheoesophageal groove, and this is the inferior thyroid artery. So next, coming to the lobes of the gland, the thyroid gland lobes you are seeing here. Each lobe has got an anterolateral surface, posterolateral surface and a medial surface. Anterolateral, posterolateral and a medial surface. The anterolateral surface you are able to see on this side, it is mainly related or covered by the infrahyoid muscles. Sternohyoid medially, omohyoid laterally. Deep to it you have the sternothyroid and the thyrohyoid. It is related to the infrahyoid muscles. Posterolateral surface is related to the great vessels of the neck. So that is the carotid sheath and its contents. So posterolaterally you can see it is related to the carotid sheath, mainly the common carotid artery inside the sheath and the internal jugular vein. In between these two you will see the vagus nerve. Okay, so that is the vagus nerve, you are able to see that, and on the left side it makes or winds around the arch of aorta to form the recurrent laryngeal nerve. Okay, posterolateral surface. Medial surface is related to two tubes, that is the trachea and the esophagus. Two muscles, inferior constrictor and the cricothyroid muscle. Okay, so constrictors are inferior, above that you will see middle, and above that you see the superior. So these three constrictors of pharynx, they are synonymous to your inner circular muscle of your GIT. Your GIT has a smooth muscle, muscularis externa, inner circular and outer longitudinal. Here these can be compared to the circular muscle, but these are voluntary muscles. Okay. Then it is related to two tubes. I told you, two muscles and two nerves. The external laryngeal nerve supplying the cricothyroid muscle, and other one is the recurrent laryngeal nerve. Okay, so that is the relations of the medial surface. So at the cross section of the neck, you will be able to understand these relations. So here you are able to see the thyroid gland. Anterolaterally it is related to the infrahyoid muscles. Posterolaterally it is related to the carotid sheath and its contents. Medially it is related to two tubes, trachea in the front, esophagus behind. Two muscles of course cannot be demonstrated in this cross section, but one nerve between the trachea and the esophagus. In the tracheoesophageal groove, you see the recurrent laryngeal nerve. Okay, in the tracheoesophageal groove, you can see that. So that is the relations of the lobes of the thyroid gland. Next, coming to the borders, it has an anterior border and it has got a posterior border. The anterior border is actually related to the anterior division of superior thyroid artery. The superior thyroid artery, what happens is, it divides into an anterior and posterior division. So the anterior division is related, is actually descending on the anterior border of the lateral lobe of the thyroid gland. Posterior border is actually related to the anastomosis between the superior and inferior thyroid artery and also the parathyroid glands. Mainly it is related to the, so you are able to see parathyroid gland, superior parathyroid and inferior parathyroid, and anastomosis of the superior and inferior thyroid arteries. Posterior border. You can see that. Okay. Then, sometimes on the left side, the thoracic duct is related close to its termination, where it is going to drain into the junction of the internal jugular vein and the subclavian vein. Now coming to the isthmus. Isthmus is nothing but a narrow connecting part which connects the two lateral lobes, and it is situated in the anterior median plane. It has got a superior border, it has got an inferior border, and it has got an anterior surface and a posterior surface. The isthmus lies opposite the second, third and fourth tracheal rings. Okay, so it is actually related to the second, third and fourth tracheal rings posteriorly. The upper border, you can see slightly to the left of the median plane, a small extension which is called as the pyramidal lobe. Okay, that is actually developmental in nature, the pyramidal lobe. Apart from that, the whole of the upper border, you can see the anastomosis between the superior thyroid arteries of the both the sides. Okay, superior thyroid artery of the both the sides, you can see the anastomosis. The lower border, actually the commencement of the the inferior thyroid vein. So the lower border, you can see the commencement of the inferior thyroid vein, and sometimes an occasional artery, the arteria thyroidea, if present, is also related to the inferior border. Okay, so that is the isthmus, as I told you. So upper border, pyramidal lobe. An extension of the pyramidal lobe is actually called as the levator glandulae thyroideae. It contains fibromuscular band. So some skeletal muscle fibers are also seen and supplied by the cricothyroid muscle, by the external laryngeal nerve, which the supplies the cricothyroid muscle, also gives some nerve fibers to these muscle fibers. And levator glandulae thyroideae, as considered by some authors, it is not a remnant of the thyroglossal duct. Okay, so that is about the pyramidal lobe and the levator glandulae thyroideae. We have discussed about the isthmus, its relations, borders and surfaces. Now coming to the arterial supply, the blood supply of the thyroid gland, it is mainly supplied by superior thyroid artery and inferior thyroid artery. The superior thyroid artery is actually a first branch from the external carotid artery. Okay, it is actually a first branch from the external carotid artery. The superior thyroid artery descends and at the apex of the gland divides into anterior and posterior division. Okay, It divides into an anterior and a posterior division. The anterior division anastomoses with the anterior division of the opposite side. It anastomoses with the anterior division of the opposite side, and posterior division anastomoses with the inferior thyroid artery. The superior thyroid artery also gives a branch to the superior larynx as the superior laryngeal artery. Superior laryngeal artery is a branch from the superior thyroid artery. The next artery is the inferior thyroid artery, which is a branch from the thyrocervical trunk. So the thyrocervical trunk is actually from the first part of the subclavian artery. The thyrocervical trunk gives three branches. One passes behind as the suprascapular artery. Goes to the supraspinatus, infraspinatus, supra and infraspinous fossa. Then it gives a transverse cervical artery, and the other branch is the inferior thyroid artery. So these we have already discussed about the suprascapular transverse cervical in the posterior triangle. Lower part of the posterior triangle, that is the supraclavicular part. We have discussed about the subclavian vessels, the third part of the subclavian vessels and branches from the thyrocervical trunk. So the next artery is the inferior thyroid artery, which is a branch from the thyrocervical trunk. Then occasionally, as I told you, arteria thyroidea ema, which is a direct branch from the arch of aorta, occasionally, if present, supplies the thyroid gland. Then accessory thyroid arteries. So these accessory thyroid arteries are from the tracheal and esophageal branches. Okay, they give additional branches to the thyroid gland as the accessory arteries. So that is the blood supply or the arterial supply of the thyroid gland. Next, moving to the venous drainage. So the veins mainly they form or they start as a plexus on the surface of the gland, which is present deep to the true capsule. And from these plexus they drain via the superior thyroid vein, the middle thyroid vein and the inferior thyroid veins. So venous drainage is by superior, middle and inferior thyroid veins. Superior thyroid vein drains into internal jugular vein. Middle thyroid vein also drains into internal jugular vein. Inferior thyroid vein drains into the brachiocephalic vein. Okay, internal jugular and inferior thyroid into the brachiocephalic vein. Sometimes another vein which is actually called as the fourth vein of Kocher, if present, also drains into the internal jugular vein. So the surgeons during thyroidectomy should actually try to look for this fourth vein of Kocher and then ligate it earlier, so that what happens to avoid any profuse bleeding. Lymphatics, upper part of the gland mainly drains into the prelaryngeal lymph nodes. Okay, from there they go to the jugulodigastric nodes, upper deep cervical nodes, which is actually called as the jugulodigastric nodes. They are actually present between the interval between the posterior belly of digastric, internal jugular vein and the common facial vein in the triangular region. The lower part of the gland mainly drains into pretracheal lymph nodes. From there, what happens is they might drain into the lower deep cervical nodes. So mainly prelaryngeal nodes for the upper part of the thyroid gland and pretracheal nodes for the lower part of the gland. The nerves supply sympathetic and parasympathetic. Parasympathetic is from the vagus and recurrent laryngeal nerve, whose function is actually not clear, whereas the sympathetics from the middle cervical ganglion, especially postganglionic fibers mainly from the middle cervical ganglion. You know, the sympathetic chain has got superior, middle and inferior cervical ganglion in the neck. So from the middle cervical ganglion, mainly what happens is this actually supplies the sympathetics to the thyroid gland. Now, coming to the development of the thyroid gland, so it is actually developed from the floor of the pharynx. So the pharynx is mainly responsible for the development of your tongue, thyroid, tonsils, the palatine tonsils, auditory tube, middle ear cavity, okay, and your parathyroid gland, thyroid gland. The pharynx, mainly the endoderm of the pharynx is responsible for that. So you have the mesoderm and ectoderm also, which gives rise to the muscles, skeletal elements. And you also have respective nerves for this pharynx because it is in the form of arches. So like how the gills have on either side respiration, so like that we have arches during our development. These arches, they fuse and finally they form a smooth contour of our neck region. Now from the floor of the pharynx, the tongue is developing. Okay, you have the lingual swellings and the tuberculum impar, mainly forming the anterior 2/3 of the tongue. So at the junction of the anterior 2/3 and posterior 1/3, you can see a long duct descending, which is called as the thyroglossal duct. So it passes deep to the hyoid bone and finally reaches the neck, where the duct, what happens, expands laterally into two bilobed masses, and that is mainly responsible for the formation of the two lobes of the thyroid gland. Okay, so it is an endodermal derivative, and these bilobed masses, what happens, they form small diverticula for the follicles, and they give secondary follicles. Thereby what happens is the number of follicles, they increase. That is how the thyroid gland develops from the thyroglossal duct. Now, apart from the follicular cells, within the thyroid gland in the histology, you can see it also has some parafollicular cells or C cells, which secretes thyrocalcitonin. These C cells are actually derived from the ultimobranchial body, that is from the fifth arch. I told you the pharynx in the form of arches, first, second, third, fourth, fifth and sixth arch, of which the fifth arch disappears and the remnant is the ultimobranchial body, which gives rise to the parafollicular cells or the C cells. Okay. So what happens is, that is how it forms, and the upper part where the duct was attached initially is actually the foramen cecum of the tongue, and the duct completely disappears. If at all it is present, the lowermost end is the pyramidal lobe, which we come across occasionally. Now, if the duct anywhere, if does not obliterate and it may present as a remnant anywhere along its descent, it forms a cystic swelling and it is called as the thyroglossal cyst. It is called as the thyroglossal cyst. Then, sometimes what happens is anomalies of the thyroid gland. One of the lobe might be absent, the isthmus might be absent. Thyroid might not descend and it will be present at the posterior part of the tongue itself, which is called as the lingual thyroid. Then, apart from its final position in the adult, if you along its descent anywhere, if the thyroid tissue is arrested, that is called as ectopic thyroids. So abnormal sites where you can find thyroid, okay, that is actually called as the ectopic thyroid, and accessory thyroid tissue is also sometimes found in the neck. So that is about the development of the thyroid gland and its developmental anomalies. So coming to the surgical aspects during thyroidectomy, total thyroidectomy or partial thyroidectomy, While you ligate the superior thyroid artery, you should ligate nearer to the gland, because if you ligate away from the gland, it is intimately related to the external laryngeal nerve. Same way, when you ligate the inferior thyroid artery, you should follow the opposite of this rule for the superior thyroid artery. That is, it is actually ligated away from the gland, because nearer to the gland, the recurrent laryngeal nerve is intimately related to this artery. So there is a chance of actually injuring this nerve. Then, in thyroidectomy, the gland is removed along with the true capsule. Both the false and the true capsule, it is removed, because deep to the true capsule you have the venous plexus. So if you try to incise the capsule and take the gland, so we might actually disturb or rupture the venous plexus, and that might lead to alarming hemorrhage. Okay, so these you have to take care. And fourth vein, Kocher's vein, if present, as I told you, in the venous drainage itself, it should be preserved, not preserved, it should be actually identified and ligated early, so that to prevent any bleeding, profuse bleeding. Okay, these are the surgical aspects with respect to the thyroid gland. Next, enlargement of the thyroid gland is actually called as the goiter, mainly seen during the hyperthyroidism. So hyperthyroidism is actually characterized by increased basal metabolic rate, tachycardia, okay, and then exophthalmos. These are some of the features you see in the hyperthyroidism. Hypothyroidism is actually manifested as myxedema in adults and cretinism in children. Okay, so that is about the hyperthyroidism and hypothyroidism. Then malignancy, thyroid cancers are also very common. So it might also appear as swellings, tumors in the thyroid gland, like nodular swellings, and mostly the tumors cannot extend above. It might actually extend posteriorly or medially and compress the neighboring structures. Okay, so it mainly extends backwards and compress the neighboring structures. So next, coming to the parathyroid glands. So you're able to see 4 parathyroid glands, 2 on each side. So 2 pairs of parathyroid glands, superior parathyroid and inferior parathyroid. They mainly secrete the parathormone. The parathormone is mainly responsible for maintaining the blood calcium levels. Okay, so for mobilizing the calcium which is stored in the bones and maintaining the optimum levels, the parathormone is very essential. It is also an endocrine gland, and as I told you, you have a pair of superior parathyroid and inferior parathyroid. Sometimes you can see supernumerary also, up to 3 pairs also is encountered, but it is very rare. Mostly 80 to 85% of the subjects mainly have 2 pairs of parathyroid gland. The superior parathyroid is mainly situated at the middle of the posterior border of the lobe of the thyroid gland. Okay, middle of the posterior border, mainly you see the superior parathyroid gland. Okay, and it lies behind the recurrent laryngeal nerve, between the true and the false capsule. Between the true and the false capsule, you can see the superior parathyroid gland. Whereas the position of inferior parathyroid gland is variable. The position of inferior parathyroid gland is variable. It is in relation to the loop of inferior thyroid artery. It might be situated above the loop, or it might be situated below the loop. If it is actually situated above the loop, then it is within the false capsule. That is, it is between the true capsule and the false capsule. Below the loop, if it is situated below the loop of inferior thyroid. If it is above the loop, then it is outside the false capsule. Okay, and very occasionally sometimes it might also be buried deep within the gland, within the substance of the gland. So mainly parathyroid gland should be preserved during thyroidectomy, not to be mistaken for any lymph node or fat. Okay, because they are yellowish, lentiform or bodies. Okay, so it is mainly supplied by the inferior parathyroid artery or anastomosis from the superior and inferior parathyroid artery. Okay, the veins and lymphatics, they actually follow the course of the thyroid gland. So nerve supply is again mainly by the middle cervical ganglion. Sympathetics from the middle cervical ganglion. So the development of the parathyroid gland, superior parathyroid gland, it is also called as parathyroid 3 because it develops from the third pharyngeal pouch. So the each, I told you the pharynx, laterally you have the pharyngeal clefts and medially you have the depressions lined by endoderm, that is called as the pharyngeal pouches. So first pouch mainly responsible for forming the eustachian tube. Second pouch, again dorsal part will take part in the formation of middle ear cavity, and the ventral part gives rise to the palatine tonsil. Okay, superior parathyroid from the third pharyngeal pouch, but finally it is called as the inferior parathyroid. Parathyroid 3 is actually inferior parathyroid, whereas the parathyroid 4 is actually the superior parathyroid in adults, which is developed from the fourth pouch. Now why? Because the upper one, the parathyroid 3, actually during its course of development, finally it migrates and comes to lie below the parathyroid 4. So finally the parathyroid 4 is actually called as the superior parathyroid, and parathyroid 3 is actually called as the inferior parathyroid. So hypersecretion of parathyroid is actually called as or produces a symptom osteitis fibrosa. So what happens is decalcification takes place because more amount of calcium is mobilized from the bones. Then apart from that you also see hypercalcemia. So too much of calcium in the blood, calcium levels increases, and renal calculi are also formed in the kidneys. Hypersecretion. Hyposecretion of the parathyroid hormone leads to mainly hypocalcemia, okay, which is the opposite of the hypersecretion. So with this, I actually complete today's lecture, and thank you very much for your patient listening.